Ahora sí. Por favor, vamos a iniciar. Apagamos todos los micrófonos, por favor. Ahí escucho un micrófono prendido. Ahora sí. Ya, ahora sí. Buenas noches con todos. ¿Cómo están? Quiero darles la bienvenida a nombre de la Junta Directiva de la Asociación Peruana de Disfagia a esta charla tan esperada. Quiero agradecer a la Sociedad Peruana de Disfagia por la confianza y, por supuesto, a la SLAD por el aval y de una manera muy especial a la doctora Renata Mancopes, quien fue gestora de este esperado evento. Sin duda, la investigación científica va cambiando muchos paradigmas, ¿verdad? En las carreras de salud y la fonoaudiología, terapia de lenguaje o logopedia, como se llama en diferentes países, pues no es la excepción. El entrenamiento y el tratamiento de las personas con disfagia, donde se aplica una serie de estrategias para compensar y rehabilitar el trastorno de la deglución, pues hoy en día se está estudiando muchísimo. Y una de esas estrategias es justamente la del ejercicio, de aumentar la fuerza de la lengua, con el objetivo de mejorar los objetivos de la deglución, como es la eficiencia y la seguridad. Este tema ha sido muy estudiado e investigado por mucho tiempo y sin duda una de las investigadoras que conocen mucho sobre este tema es la doctora Catriona Steele. Y justamente hoy la tenemos con nosotros en esta charla. La doctora Catriona es miembro de la ASHA, es científico, directora del Laboratorio de Investigación de Rehabilitación de la Deglución, Instituto de Investigación CATE, Instituto de Rehabilitación de Toronto, de la Red de Salud Universitaria. También es profesora de Patología del Habla y Lenguaje del Instituto de Ciencias de la Rehabilitación, Facultad de Medicina de Temerty, en la Universidad de Toronto. También dicta cátedra de investigación en Canadá de deglución y procesamiento oral del alimento nivel 1. Es consejero de la Junta Directiva, Iniciativa Internacional de Estandarización de la Dieta para la Disfagia, la conocida ITSI, y presidente electo de la Sociedad de Investigación de Disfagia. Y por supuesto, este es un CV resumido, es autora y coautora de muchas investigaciones, más de 100 investigaciones. Así que quiero darle las gracias por aceptar esta investigación y por supuesto por todo el trabajo que hace por la especialidad. Bienvenida, doctora Catriona.
Ready for me?
Muchísimas gracias por aceptar.
Well, thank you, and good evening, everyone. I'd really like to begin by thanking Dr. Ramos and Dr. Para for the invitation to speak tonight about tongue strength training in the treatment of dysphagia. And these are my disclosures. I also want to take a moment to recognize the members of the Steele Swallowing Lab who are shown on the slide, including Dr. Renata Mancopes, who's with us tonight and will also be able to help you with translation if needed. And this is an outline of the issues I want to cover tonight in this talk. So let's start by looking at the rationale for targeting tongue strength in dysphagia rehabilitation. The tongue, as we all know, plays a key role in swallowing. It plays a function both in oral bolus control and in generating the forces that propel the bolus through the pharynx. And you probably remember from your anatomy lectures that the tongue contains an interdigitated network of 4 intrinsic muscles arranged in longitudinal, transverse, and vertical directions. And these muscles are responsible for changing the shape of the tongue, while 4 extrinsic muscles are responsible for changing the position of the tongue within the upper aerodigestive tract. Now, both bolus control and bolus propulsion in swallowing are achieved by the application of tongue pressure to the bolus. During the oral phase of liquid swallowing, the anterior, posterior, and lateral margins of the tongue are described to elevate to create a pressurized chamber that contains the bolus. The anterior tongue is typically anchored on the alveolar ridge, And contraction of the longitudinal muscles of the tongue then pull the mid and posterior portions of the tongue forward towards this anchor point. And this generates an anterior to posterior pressure wave, which squeezes the bolus backwards toward the pharynx. This pressure reaches its peak as the bolus enters the pharynx, and movement of the tongue back down to its resting position creates a pressurized narrowing that chases the tail of the bolus down through the pharynx. Now, our interest in tongue strength within the field of dysphagia really dates back to this seminal article by Dr. Mark Nicosia from the lab of Dr. Joanne Robbins in 2000, in which age-related reductions in maximum isometric tongue pressure were identified. This is one of the first available studies where tongue pressures were measured during both strength and swallowing tasks, and they used equipment called the K-Pentax Swallowing Signals Lab, which had a 3-bulb tongue array which was glued along the midline of the palate. And when they compared pressures in 10 younger adults with a mean age of 51 years to 10 older adults with a mean age of 81 years, Nicosia and colleagues showed significantly lower maximum isometric pressures at the anterior, mid, and posterior palate sensors in the older group. By contrast, however, notice that no significant differences in tongue to palate pressures were seen across age groups in the swallowing tasks. Nicosia and colleagues did, however, observe that the older participants were more likely to show a multi-peaked pattern of pressure generation during swallowing, which they interpreted as showing greater effort in pressure generation. The Nicosia article really led to 3 key ideas in the field of dysphagia. The first was to introduce the concept of lingual functional reserve, which is the difference in pressure generation between maximum anterior isometric pressures, or MAPE, and regular effort saliva swallowing pressures. And because MAPE values get smaller in older adults, this lingual functional reserve gap also gets smaller. Nicosia and colleagues concluded that this reduction in lingual functional reserve places older adults at a disadvantage. And based on their observations of an association between multi-peaked pressure generation patterns and aspiration in their study, they argued that reduced pressure generation capacity represents a risk for aspiration. Second, this article was the first to use the term sarcopenia when describing age-related changes in tongue muscle. And this really gave birth to an interest in the field in using resistance exercise to prevent or reverse these age-related changes in muscle strength, and also to an interest in lingual resistance training as an intervention for dysphagia following sports medicine principles. So before we look at the evidence for lingual resistance training, I want to suggest 2 articles to you for further reading. The first is this article by Dr. Laurie Burkhead Morgan, which discusses the principles behind exercise-based approaches to strength training. And the second is this tutorial article by Drs. Jeff Klein and Teresa Jones, discussing principles of neuroplasticity, which should be considered when designing exercise-based interventions for dysphagia. These include the use it or lose it and the use it and improve it principles, as well as the ideas that time, intensity, and repetition can influence outcomes as well as task specificity and salience. So now let's look at some of the evidence regarding lingual resistance training. As mentioned previously, healthy adults experience an age-related loss of tongue strength. And this finding has now been replicated in numerous studies since the original paper by Nicosia and colleagues. And building on that finding, Dr. Robbins embarked on research to explore the potential of exercise, and specifically lingual resistance exercise, to rebuild tongue strength in healthy older adults. Dr. Robbins developed a training protocol involving biofeedback regarding tongue pressure generation using the Iowa Oral Performance Instrument that is shown here on the slide. And this device involves a 2.7 milliliter air-filled bulb that you place in the mouth and squeeze against the palate with your tongue. And when air is squeezed out of the bulb and along the connecting tube, this is registered by a sensor inside the device and shown in kilopascals on the screen. And over the past 20 years, several other devices for measuring tongue pressure have been developed. But at the moment, models using an air-filled bulb like the IOP are the most widely available. This slide shows the protocol developed by Dr. Robbins for lingual resistance training, which involves principles of repetition and intensity or load. It's an 8-week protocol in which lingual resistance tasks are practiced 3 times a day on 3 non-consecutive days of the week. And in each practice session, there are 10 repetitions of anterior isometric tongue presses and 10 of posterior isometric tongue presses. The load is set by targeting pressures that are at 60% of the person's maximum isometric pressure in the first week, and then increasing that target to 80% in week 2, and then remeasuring maximum and maintaining a target of 80% every 2 weeks from that point forward. So what kinds of outcomes can we expect from this sort of protocol? As you can see in the graph, Dr. Robbins and colleagues showed that healthy older adults were able to increase their maximum anterior isometric pressures by about 20% versus baseline across the course of this 8-week protocol. Notice here also that these participants began the study with mean makes of about 40 kilopascals. And this is a value that is commonly used in the literature as a threshold for deciding that somebody has normal versus reduced tongue strength. I should just mention that you may get different measures on different instruments. And so the 40 kilopascals is the threshold used with the IOP. Dr. Robbins then continued on to a second study using the same protocol, but this time in a group of 10 adults with post-stroke dysphagia. And these individuals began their treatment with maximum tongue palate pressures that fell below 40 kilopascals. And over the next 8 weeks, their maximum isometric pressures also increased. But what about their swallowing outcomes? Interestingly, in the Robbins study, the patients started with average swallowing pressures of 11 kilopascals. And this is also reduced compared to the values of about 20 kilopascals that we would expect to see in healthy adults based on the work of Nicosia and colleagues. Robbins and colleagues showed that swallowing pressures also improved over the course of treatment, reaching a mean value of about 16 kilopascals. But probably the most interesting result reported in the study was the finding that penetration aspiration also improved based on a standardized video fluoroscopy. At the beginning of the study, the group showed mean penetration aspiration scale scores of 6, with some occurrences of both penetration and aspiration. By week 4, the scores had shifted so that there were no longer episodes of aspiration, but still some of penetration. And by the end of treatment, further improvement was seen so that the scores were largely in the normal range. And this is an exciting finding that suggests possible links between tongue strength and swallowing safety. And it has led both to proposals that tongue strength should be measured as a method of screening for possible dysphagia, and also to more widespread use of lingual resistance training as an intervention. But there is a problem here, and that is that this study did not control for spontaneous recovery. And because these patients were all in the first few months after a stroke, spontaneous recovery is a possible explanation for the finding. Unfortunately, however, evidence regarding swallowing outcomes after lingual resistance training has mixed results. There have actually been a few systematic reviews recently looking at this issue, and one of those is shown here, led by my recent student, Dr. Sana Smeoui. And after an initial search yield of more than 1,300 articles, Sana found 7 articles that reported video fluoroscopy measures of swallowing outcomes after a program of lingual resistance training in adults with dysphagia. And across those 7 studies, the primary device that was used for measuring outcomes and providing biofeedback was the IOP. However, we found a huge degree of variation across these studies with respect to treatment duration, frequency, and tasks. And this really made it inappropriate to perform a meta-analysis. Treatment dose was a little bit more uniform, with sessions typically including at least 30 task repetitions. However, all of these studies were found to have a high risk of bias. And here there were 2 particular issues that stood out as threats to drawing strong conclusions regarding the evidence. These were the lack of control for spontaneous recovery, just like that original Robbins study. And this was particularly true amongst stroke patients. And the second issue was a failure to monitor adherence, particularly in studies involving a home practice. In terms of the overall conclusions from the reviews, Sana did find evidence to suggest that isometric tongue pressures show improvement after treatment in the studies where they were measured. So we're able to strengthen the tongue. Mixed results were found, however, with respect to improvements in swallowing safety measured using the penetration aspiration scale. And mixed results were also found with respect to improvements in post-swallow residue. And here, different methods of measuring residue across studies contributed to the uncertainty. And finally, the review did not find any convincing evidence of systematic changes in timing measures of swallowing related to lingual resistance training. In other words, this review found convergent evidence that lingual resistance training can be expected to lead to improved tongue strength, even with heterogeneity across studies in the types of tasks that were performed. But the review found insufficient evidence to suggest that swallowing outcomes, either safety or efficiency, can be expected as an outcome of lingual resistance training. So these findings led us to go back and question the physiologic rationale that we were using as the basis for recommending lingual resistance training in our own patients, and specifically to exploring the link between tongue strength and swallowing function in subacute stroke patients. And our specific question was to ask whether swallowing function and physiology in a group of subacute patients recovering from supratentorial ischemic stroke showed common profiles associated with reduced tongue strength. And in this small group of patients who had a similar stroke history, and all of whom were evaluated within 5 weeks after their first stroke, actually showed that reduced tongue strength was not associated with a predictable profile of swallowing physiology. And so this may partly help to explain why previous studies of lingual resistance training have shown mixed results in terms of swallowing outcomes. So to wrap up, let me summarize the information we've covered. First, we know that reduced tongue strength on maximum isometric pressure tasks is something we can expect to see in healthy aging, and it may also be a feature in people with dysphagia following stroke or with other neurological diagnoses. Second, tongue strength may be preserved for swallowing tasks so that the deficits are seen on maximum strength tasks, but not on swallowing tasks. So the link between reduced tongue strength and specific patterns of impairment in swallowing physiology remains unclear. And fourth, studies across the literature concur that lingual resistance training leads to improved tongue strength, but whether these changes also translate to improvements in swallowing is still a big question. So I'm going to stop there and give us lots of time for questions. And I thank you for your attention and look forward to the discussion. Good. There must be some questions.
Ahora sí, ahora sí. ¿Se me escucha?
Yes.
Pues interesante todos los
I
estudios
can,
que han
thank you.
presentado, doctora. Muchísimas gracias. Vamos a ver algunas preguntas. Pues mire, hay algunas cositas como por ejemplo, ¿qué hay sobre el desentrenamiento? Que también es conocido como principio de reversibilidad, ¿no? O sea, sabemos que si uno trabaja, en este caso, un ejercicio con el objetivo de mejorar la fuerza, de hecho que se mejora la fuerza. Entonces, y la fuerza es algo que se debe mantener en el tiempo, porque si uno deja de hacerlo, pues disminuye la fuerza, ¿no? Con ese razonamiento, diríamos que si trabajamos la fuerza para mejorar los objetivos de deglución, tendríamos que trabajarlo toda la vida, ¿no? O sea, para tener una deglución sana, digamos, ¿no? Bajo ese principio de estos estudios. Quería su opinión, doctora.
Yes, I think this is a very interesting question. And if you think about going to the gym to strengthen or exercise other muscles, what generally happens in sports medicine is that we are encouraged to exercise to the point of fatigue or to the point where we can't repeat the task anymore and we're tired. And then we're encouraged to rest and then come back the next day and repeat that exercise. And that's the kind of principle Dr. Robbins was trying to build into her protocol with targets of 60% and 80% of maximum as the strength target. And she had, if you remember, 30 repetitions in the front and 30 repetitions in the back every day. There have been studies trying to figure out whether those are the right numbers to choose. So is 60% the right target, or 80%, or 100% of maximum? And in fact, there's a study from Belgium that found no difference in outcomes between people exercising at those 3 different levels of load. And then there are questions about how many repetitions would we have to do to get tired. And the tongue turns out to be a really fatigue resistant organ. And so there's still, I think, a big question about whether the studies that we have exercised the tongue enough to lead to, we see strength changes, but are we really using these principles of sports medicine. And then with the question of maintenance, there have been some studies that have tried to stop doing the exercise after a course of therapy and see whether tongue strength declines. And it doesn't tend to drop off. And so you could ask why. And I think one could argue that we use our tongues all day in speaking and also in swallowing. And so perhaps those activities serve as a sort of maintenance for the strength gains that we've achieved. But we don't really know the answer to the question. And one possibility is that we just haven't exercised the tongue enough to see that evidence of a loss of strength when we stop practicing.
Ok. También tenemos una pregunta de uno de los miembros de la Junta Directiva y la verdad que es muy interesante, ¿no? Porque cuando hablamos de la deglución, pues estamos hablando de una actividad donde cambiamos la vía respiratoria a una de deglución en un periodo de menos de un segundo, ¿verdad? Y no solamente eso, sino sucede una serie de eventos, no solo de movimientos, sino también sensoriales, sensitivos. ¿Y en qué deberíamos realmente centrarnos? De repente estamos muy enfocados en ganar fuerza, pensando que esto puede mejorar la deglución, y de repente estamos dejando de lado la habilidad, ¿verdad? La habilidad que es trabajar con la función, de repente con la velocidad, con la coordinación, como hay muchos ejercicios, ¿no?
Yeah, I think this is a great question as well. And my personal opinion would be that if you're going to work on strength tasks, that you need to also include swallowing tasks and generalization tasks in your therapy to give a hope of that carryover. And I also think that the person asking the question has pointed to the fact that swallowing can go wrong in many different ways. And so a big challenge in choosing appropriate therapies for a patient is first to do a comprehensive assessment to understand which components are not functioning properly, and to then try to target those in therapy. So tongue strength might be one of those components, but it may not be the only thing that's wrong. And that, I think, is another reason why the studies that we have available show mixed results, because the people enrolled in those studies probably had other things wrong with their swallowing, not just tongue weakness. And so it's probably impossible for us to find a group of people who only have tongue strength as the problem. And so when we look at the outcomes, the other things may be preventing positive outcomes or influencing the kinds of outcomes that we see. So at the moment in our lab, we are very interested in tongue strength as something that can be used to perform an effortful swallow effectively. So can we train people to do an effortful swallow by generating greater tongue pressure? And we're hoping that that will translate to improvements in swallowing efficiency and better bolus clearance. And I think that is a logical progression. We've just done a small study in Parkinson's disease, and we did see about half of the participants showed positive change and about half didn't. And so again, mixed results in people who had a number of things wrong with their swallowing.
Muchas gracias por su respuesta, doctor. Y la última pregunta, doctor. La última. Yo creo que es importante acotar que estos estudios se hicieron en pacientes con ACV, ¿verdad? Entonces yo quería preguntar si hay estudios en otras poblaciones y si se puede extrapolar, porque de hecho que se hace en la práctica clínica, a otras como por ejemplo pacientes con Parkinson, pacientes con disfagia por cáncer de cabeza y cuello, por ejemplo.
Mm-hmm. So most of the studies of tongue strength training have been done in stroke at this point, but not all of them. And in particular, there's a study by Nicole Rogas-Puglia at the University of Wisconsin-Madison, where they took all sorts of people into the study, and the requirement was that they had tongue weakness and either aspiration or residue. So they had mixed etiologies, and they showed mixed results. As I said, we're doing some work right now in people with early stage Parkinson disease, and we did see, first of all, they liked interacting with the biofeedback equipment. And if you think about treatment for Parkinson disease for walking, for example, if you give people something like a biofeedback device, they tend to work very well with it in Parkinson's disease. So we found that to be true with the IOP. It helped them to focus and perform the task well. Interestingly, we weren't really working on strength improvement. We were working on effortful swallows. And so we didn't see huge changes in tongue strength, but we did see some changes in swallowing. I think it also makes sense in people who have had head and neck cancer, and the group in Belgium led by Gwen van Nuffelen is doing a lot of work with tongue pressure training in head and neck cancer patients. I'm not sure whether it's particular sites, but they have several studies from their group. So I think this therapy is something that you could consider for a variety of patients.
Ok. Bueno, doctora, muchísimas gracias por su tiempo y por supuesto por compartir sus conocimientos. Muchas gracias, Renata, también por ayudarnos a gestionar esta charla científica. Gracias a los miembros de la Junta Directiva, por supuesto a los participantes. Esperamos con la doctora en otro momento, porque no en vivo. Muchas gracias a todos. Que tenga buenas noches.
That would be lovely. All right, thank you very much.
Gracias, muchas gracias. Gracias, Renata, nos estamos viendo. Chao, chao.